Okay. Assalamualaikum. My name is Shahidah, and me and my colleague will present about benign and malignant breast disease. Next. So this is the table of content, and the introduction will be presented by me and followed by my colleague. So next. So the first one is introduction, we go to epidemiology for worldwide. According to WHO, there were 2.3 million women diagnosed with breast cancer, and the breast cancer was is second highest has second highest incidence for both sex, and for number of deaths, breast cancer is the sixth leading cause of cancer mortality, where the deaths was the deaths that was recorded were around more than 600,000. And then next, so for uh, worldwide for ethnicity, the highest incidence and mortality among Asian population. So next. So epidemiology in Malaysia, the breast cancer is most common affecting women. The age started to increase at 25 years old and peaked at 60 to 64 years old. Regardless of gender, breast cancer contributed to 19% of all new cancer cases diagnosed in 2012 to 2016. And the incidence was highest among Chinese, which is 40.7 per 100,000, and followed by Indian and Malay. And next. So these are the risk factor can be divided into non-modifiable and modifiable. So for the age, the incidence started to increase at the age of 25 and peak at 60 to 65 years old. And gender, the female is more affected than male. And family history, especially in the young patient, they are a carrier for pathogenic variants such as BRCA1, BRCA2, and other pathogenic variant. And the next one is reproductive factors. Early menarche and late menopause is the risk factor for luminal tumor, and history of neoplastic disease of breast, which is patient with carcinoma in situ, and atypical ductal hyperplasia and lobular hyperplasia has increased risk to develop breast cancer. And for breast density, um, for women has extremely dense breast and scattered fibroglandular density, has 2 to 4 times higher risk to develop breast cancer. For modifiable, which are reproductive factors for nulliparity, women, lack of breastfeeding, and older age at first life childbirth. The second one is hormonal factor for for patients who have used more than 10 years oral contraceptive pill, and hormonal replacement therapy has mild risk. And for the lifestyle, overweight or obese has increased risk of postmenopausal breast cancer, and alcohol consumption can develop invasive breast cancer, especially among postmenopausal patient. So for radiation exposure, which the patient for the patient has received therapeutic radiation for Hodgkin disease, or for therapy for breast cancer, they can develop a contralateral breast cancer. So next. So we move on to pathophysiology. Breast cancer developed due to DNA damage and genetic mutation that can be influenced by exposure to estrogen, such as the patient may have inherited mutation from BRCA1 or BRCA2. If the patient has family history of breast cancer and ovarian cancer, and environmental factor that I have said just now, and hormonal changes, it can lead to damage and failure of repair gene, and will which can uh, produce a mutation in genome, which lead to activation of growth, promoting oncogene, and result in cell prolifer- profil- proliferation, and result in malignant neoplasm. For altered in gene and that regular apoptosis can decrease the apoptosis, and this can lead to tumor progression and lead to malignant neoplasm. Okay, so next. So these are classification of breast tumor, which can be divided into malignant and benign. So for all there are four types of benign benign tumor, which are non-proliferative, proliferative without atypia, atypical hyperplasia, and miscellaneous. So atypical hyperplasia, which are atypical ductal hyperplasia, and atypical lobular hyperplasia, can has higher risk to develop breast cancer. So next. So classification for malignant, they are divided into non-invasive, invasive, and others. So for non-invasive, it is malignant cell arising from terminal duct lobular unit. However, ductal carcinoma in situ has distal lobular architecture. Lobular carcinoma in situ has no distal lobular architecture. So for invasive, there are two types, which is invasive ductal carcinoma and invasive lobular carcinoma. And for others, there is inflammatory breast carcinoma. So that's all from me.
Assalamualaikum warahmatullahi wabarakatuh. I'm Intan. I will continue with triple assessment. The triple assessment for breast disease, it consists of clinical assessment, imaging, and histopathology. So by combining all the three results, it have the specificity of more than 99% to rule out malignancy. So for clinical assessment, what we assess is by taking the history and also physical examination. For imaging, there are three modalities, which are mammogram, ultrasound, and magnetic resonance image. And the last one is the histopathology, which comprise of FNAC, needle core biopsy, and also surgical biopsy. Next. So these are among the presentation of breast disease, such as patient can come with painless lump, painful lump, pain and tenderness, but no lump, nipple discharge, change in nipple and areola, changes in breast and shape. Next. So for clinical assessment, from history taking, our aim is to look for the risk factor from the patient. So we have to take history on the lump, if there's any, the history of prostate illness, such as the duration, the onset, and the first symptom that brings patient to seek treatment, associated symptom, the progression of the lump, and persistent multiplicity, and also the any previous history. And then the risk factor, as discussed from by the first presenter just now, such as patient age, history of taking any OCP, early menarche, late menopause, nulliparous, and the listed there. And also we also have to ask if there's any constitutional symptom. Next. And then we also ask if there's any extension to nearby tissue.
Okay, student, this one is for your year 3. Okay.
Okay.
Now you are talking about principle of management, your topics. So all these things not supposed to be in your slide.
Okay, sorry.
Proceed.
Alright. Okay, next.
Same.
Okay. Okay, next.
Proceed. Okay.
So the second part of the triple assessment is imaging. So our aim for imaging is for localization. It is the first line investigation, which is it should be preceded of from biopsy whenever needed. So there are three components which can we can modalities we can use, which are ultrasound, mammogram, and MRI. So as you can see on the picture above, for patient less more than 35 year old, the breast density is less denser than the one young at younger age. So it is preferable for us to use mammogram as our modality for patient more than 35 year old. But there's also time when we have to use mammogram at patient younger than 35 year old when they have a risk factor of having breast cancer. Next.
Okay, why the patient less than 35 years old has a more dense breast?
Because of the presence of duct.
No, look at your slide. Breast density
The
describe the
the fat.
difference between the fatty tissue and fibroglandular tissue. So what's the difference between less than 35 and more than 35?
The older age have more fatty tissue at the breast.
Okay, so what it means when you look at your picture imaging, the one that you showed just in the slide.
As the women grow older, the breast will comprise more fat as compared to younger. They have fibroglandular more in their breast.
Yeah, so what do you see from the image? The
Um,
difference.
the younger age, the
Look at the image, Image yang you letak tu ada empat tu. What's the difference between the images?
there's more the, the older
Okay,
age.
more whitish area,
Wait.
isn't it? In the
Yes.
less than 35 years old, in a dense breast, compared to the fatty breast density, which is more of grey rather than whitish. So what it means in terms of imaging?
We can visualize microcalcification or any features of carcinoma.
Microcalcification you can see from the mammogram. What does it mean? The denser, what are the color of lesion?
Whitish also.
Whitish. So, meaning,
We can visualize better in older age for mammogram.
yes, because of the density, isn't it? Because the denser the breast, okay, the whitish, the mammographic imaging will be. Okay, it is more, you can miss the lesion. Okay, because the lesion usually whitish in color also. So it can mimic, okay, it can mimic um the lesion, the underlying lesion. Okay. What do you mean the aim of imaging for localization?
Um, we can look. We can know where the origin of the lump in the breast.
Based on your clinical examination, you know already where is the lump.
Oh. Mm, I will remove it. Like I will update the slide.
So what is the objective of doing imaging in triple assessment?
We went to different.
Ni soalan-soalan exam you all ni tahu tak? Waktu
We
you all ambil long case.
we went to look for the features from the imaging. if it's suggestive of malignancy or benign.
Okay, good. Lagi, what do you
And
call
if
that?
BRATs,
Yes, you want to score the lesion. Okay, birak scoring. Okay, lagi, what else? The purpose.
um, we
Ni imagine, you can feel the lung is there, which quadrant, isn't it? Sometimes
mm,
you can. What are other purpose other than birak scoring?
um,
Because you want to
we went
detect
to
other lesion lah, yang small lesion that you cannot feel by your hand. Okay, maybe you feel the lump on the left breast. What about the right breast? You need to screen the right breast also because when there is one lump, you need to screen for other lump, either at the same breast or at the contralateral breast. Okay, proceed.
next. Okay, these are the three modalities for mammogram. We usually do for age more than 35-year-old because of the density of the breast and fibroglandula just now. From mammogram, it allows us to detect mass lesion, areas of parenchymal distortion, and or also any microcalcification. For ultrasound, we usually do for less than 35-year-old, and we can see the different type of lesion, such as if there is cyst, it is well circumscribed, smooth margin, and echo-free center, just like in the photo beside the table, or other benign region, which can appear as smooth contours, round or oval shape, with internal echoes and well-defined anterior and posterior margin. And for carcinoma, we can see it is characteristically irregular walls. For MRI, it is a high sensitivity modality, um, and it is an accurate way of imaging. However, it is not usually done as the first line. Um, and okay, that's all. Next. So this is the BRAT score just now that we mentioned about breast imaging reporting data and system, which is a scoring system that used to describe the three modality: mammogram, ultrasound, and MRI findings. So if the BRAT score is 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 at 5 F4, which is suspicious for abnormality. This is when we should consider for biopsy, uh, 4, 5, and 6. So other indication for biopsy includes BRAF 4, 4 or 5, and also if the patient have clinically suspicious palpable mass, despite imaging is not is not supportive of malignancy. Next. So this is the our third part of.
Go back to the previous slide.
Oh, okay.
Okay, birak score it's not that for birak score there is for A, B, C. Okay, so you need to look at which biraks are you talking about. Okay, biraks for A, B, C. Okay, it doesn't mean that biopsy should be considered. Biopsy should be performed, not considered. Kena buat, kena buat. Okay, why are you talking about? No, why birak score is very important?
Mm, because we don't want to.
What is the purpose of birak score actually?
We want to know if it's benign or malignant.
Okay, you want to categorize. Okay, so what is the importance of categorizing this lesion? Why? You dah dapat birak 2, birak 3, so what?
Uh, I think because of the management, because
Okay, what will determine your management based on the category? Kenapa you nak kena tahu birak skor ni? Untuk your management ni, kenapa? Because you didn't put the chance of malignancy in this slide. Okay, when you're talking about birak score, you need to know the risk of malignancy. Okay, for example, birak 1. What is the chance of getting cancer in birak 1? Why the management is just normal follow up?
the risk is less than 1%.
Okay, the risk is less than 1%, basically almost zero. Okay, so what about birak 3?
The probability of benign is higher, which is more than 98%.
Birak 3, 98%.
Benign, 90% to be benign.
No, what is the risk of getting cancer? Risk of getting cancer, risk of getting cancer. You know what it means or not? We're talking about the likelihood of getting cancer. For example, biras 1, it's less than 1%, almost zero. What about biras 3, biras 4, biras 5? The risk of getting cancer.
If BRATS 4, it is 25 to 74% have risk of
Mana you dapat nombor-nombor ni semua?
mm, okay,
It's not 25%. It's too high.
3 to 94%. Miss.
3 to 94%. Okay. So that's why it depends on the biras for A, B or C. So it has a quite big range there. Okay. So the reason why you want to do birak scoring is for the categorization of the lesion. Why you need to categorize the lesion? Because you want to know the likelihood of getting cancer in that lesion. Okay, for example, birak 3, the risk is less than 2%. It's still low. That's why uh, the management is short interval follow up, because there is still risk of malignancy, but it is low. What about BRAS 4? BRAS 4, there is already suspicious of malignancy, but it depends on the which one, A or B or C. Okay, because in BRAS 4A, the risk is less than 10%. Okay, in B, 10 to 50%. In C, 50 to 95%. So the risk is very high in that case. Okay, B and C is high. Okay, that is why in BRAS 4, you need to do tissue biopsy. Okay, tissue biopsy. BRAS 5 lagi lah. Wajib lagi. Okay, because of the risk of getting cancer. So you need to diagnose this patient whether this is malignancy or not. Okay, proceed.
Okay. So the next one is histopathology. One of the modality is fine needle aspiration cytology. So we use 21 to 37 gauge for this. So it provide rapid confirmation of suspected malignancies. So from from fine needle aspiration cytology, we are able to differentiate between malignant and benign. So the reason why we do FNAC first before the true cut biopsy is because of cosmesis reason. Due to the larger needle used in true cut biopsy, it causes a bigger scar as compared to FNAC. So the benefit, the pros of doing FNAC is less
Mana
invasive.
you dapat uses 21 to 27 gauge needle ni?
I I I found on up to date, miss.
Okay, have you seen how FNAC being done?
Not yet.
Not yet, you already 5th year. Takkan masa third year tak pernah pergi tengok FNAC? I think one of your in the logbook also, FNAC also part of it, isn't it? Or through card biopsy. Can't remember. You should go and watch all this procedure, how it's being done. The needle use is very small. Okay, in FNAC, you don't give LA because the needle use is too small. Hmm? Oh,
Uh,
all right, proceed.
Thank you, Miss. I will correct this slide. So the cons of using FNAC is that it has the possibility of have false negative, and then it is dependent on cytologists, and the 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 most important part is it is unable to differentiate between invasive and in situ cancer.
Okay, why true cut biopsy is not done in the first line in a benign appearing lesion? It's not because of cosmesis. Have you seen how true cut biopsy being done?
Also not yet, Miss.
True cut pun tak pernah aku tengok juga. So apa yang you all buat untuk breast case ni? Hmm? True cut biopsy ni almost every week or every month confirm ada untuk true cut biopsy ni. The wound for true cut biopsy is very small, about 2-3 mm. So do you think the reason is cosmesis? Of course lah, no. Okay, no. Which one to do, his FNAC or true cut biopsy depends on the size of the lesion also one, and also the birak scoring. Okay, kalau you nampak that lesion is birak 5, you're not going to do FNAC in that patient. You want to do true cut biopsy because of high yield. Okay, because you want to apa tu, increase the sensitivity and specificity of the test. That's why you do true cut. Okay, you can get more tissue so that you can have a proper diagnosis. If not, sometimes FNAC can give a
False negative.
more apa tu, because of less sensitivity and specificity. So sometimes dia akan the apa tu, the results gonna be like atypical cell, non-diagnostic. Okay, you should have a better sampling lah with true cut biopsy. Okay, okay, next.
Next, the next one is true cut biopsy, or also known as core needle biopsy. It is done as the first line for highly suspicious malignancy. So from the true cut biopsy, other than it can differentiate between benign and malignant, it is also help to differentiate between an in situ or invasive carcinoma. Because these two diagnoses will have different management. So the pros of using true cut biopsy is it is a definitive preoperative diagnosis, and we can differentiate between the in situ and invasive carcinoma. For surgical biopsy, it is reserved to be done after the true cut biopsy has been done twice, repeated, and still show negative on a highly suggestive for malignancy case.
What do you mean by surgical biopsy?
We
Is it
do
excision biopsy? Incisional biopsy? Which one?
we do um, the incisional biopsy.
The incisional biopsy. So what? Okay, that is called incisional biopsy. Surgical biopsy is too broad. Okay, surgical biopsy ni can be excisional biopsy, can be um, incisional biopsy. Okay, can be what, local excision also. That one also excision also. Okay, sorry, what local excision is not part of it. Okay, basically excisional and also incisional biopsy. So when you're talking about apa tu, in this kind of patient, it should be cases to case basis. Okay, uh, it's not to be done after repeated through cut negative. No, with highly suggestive omniscience, this statement is wrong. Okay, because it is too broad and dia bercampur aduk sekali this statement. Okay, in a for example, in a ulcerated breast lesion, okay, you don't do FNAC, you don't do true cut biopsy, but you do push biopsy or incisional biopsy lah. Okay, uh, okay, in that kind of patient, you don't do true cut, you don't do FNAC, so it's not a repeated true cut negative, then you do that kind of biopsy. Because you know when the breast is already ulcerated, the tumor is already in front of your eyes, you can just take chunk of tissue, okay, for biopsy. Okay, proceed.
Next slide. So the last one, we do surgical biopsy, which can be either incisional or excisional biopsy. So for incisional biopsy or wedge biopsy, we remove only part of the lesion. The removal of wedge tissue includes the normal tissue, and we also do the
Okay, if you look at your picture, okay, and also your description, okay, removal of a waste tissue including the normal tissue. Okay, the normal tissue, if you, kalau you tengok you punya gambar ni, the normal tissue is at the deeper area, isn't it?
yes, miss.
So the lesion ni, you nak kena cocok dalam mana? Okay, so this is not the way you do incisional biopsy. Incisional biopsy or wedge biopsy you do at the edge of the lesion, at the edge. Maksudnya dekat mana? Dekat border tu, border of the lesion. Okay, so you take a chunk of it. So you kena alih sikit you punya ni. Okay, at the edge of the lesion. Because you akan dapat the normal tissue there which is more superficial. Okay, and also the lesion. Because in this kind, when you do wedge biopsy, you do a backside procedure. You can give some LA and then you take about 1 centimeter lesion, isn't it? So kalau boleh, you tak naklah go deeper because in this kind of lesion, it will bleed. It will bleed and it difficult sometimes to control because it is tumor, fragile, vascularized. Okay, sometimes when you do wedge biopsy, after that you need to suture pula because of the bleeding. So of course you want to avoid going apa tu, too deep. Okay, the risk of bleeding is higher, and some more in tumor usually the tumor is fragile, so you nak bite dekat mana, you nak buat hemostatic suture ni, you nak apa tu, you nak control bleeding macam mana, you bite cut through, you bite cut through, so you tak boleh nak suture. So that is why the best way, the best area is the edge of the lesion. Okay, proceed.
Thank you, miss. I think that's my last slide.
Hello and Assalamualaikum everyone. I will present the next part of this presentation, which is management of benign breast diseases. Next slide, please. Okay, first we'll start with traumatic fat necrosis. Why I choose this as the first one is because whenever we saw a patient with breast problems, one of the first thing we ask is if there is any trauma, right? So, traumatic fat necrosis is an area of fat necrosis that can mimic carcinoma clinically and radiologically, but it occurs due to trauma. And it is associated with hard irregular lump with skin dimpling. As you can see in the pictures, the lesion is stellate kind of lesion, and in the radiological even in radiological it looks like it is cancerous. So that's why in management, mammography will show stellar area with of distortion with calcification. Therefore, core biopsy should be done with to rule out carcinoma, and the sample from the core biopsy should be sent for HPE for further investigation. Either this lesion is cancer or it is due to traumatic fat necrosis. Okay. Next is fibrocystic breast disease. It presents a single lump or areas of lumpiness which are painful and tender, and it usually occurs in premenses. Patient that are premenses. Uh, eh, I'm sorry. It is painful and tender pre-menses, before menses. I mean, and it is most common presentation in 35 to 45 and 45 years old. So the examples are as shown in the figure 445.20, and of course the management, first management would be to must exclude cancer. So how is by cis aspiration? By cis aspiration. So for cis aspiration to exclude cancer, the aspirate must not be blood stained. The lump should disappear after the cis aspiration, and the cis should not recur. Um, um, to If the patient presents with clinical symptoms, minimal in 3 months, we should give them gamolenic acid at high doses, GLA, and usually they would resolve. 90% of them would resolve with this treatment. And to those with moderate or severe cyclical pain, diazole and bromocriptine is one of the best choice, which in which 70% could reduce the pain. However, it comes with substantial side effects such as acne and hirsutism, as well as dizziness. Next, please. Next is breast cysts, which usually would occur around for patients around 40 or 50 years old, who are perimenopausal, and this is due to the change of in hormone environment. It presents with sudden and discomfort with tenderness over the lesion, and it could be uh, multiple braces, and it could be recurrent. The management is mainly is needle aspiration. Um, so if from the needle aspiration it is not blood stained and resolved completely, there is no further treatment that is required. However, if there is residual or fluid blood stain and the cyst reoccurs repeatedly, core biopsy or local excision for histological diagnosis should be done. If prior to the aspiration there is presence of solid component, then um, it is advisable to take true cut biopsy first to exclude cyst adenocarcinoma. Okay. True cut biopsy, you can see the example through the from the picture I've provided. Next slide, please. Next is the infection of breast, which can be divided into lactational mastitis and non-lactational mastitis. Why? Because lactational mastitis is one of the commonest breast infection that usually occurs in patients who are lactating. So, lactational mastitis is usually occurs during 3 months of breastfeeding, and it is due to cracked nipple or poor feeding technique, which can cause milk stasis. So, from this cracked nipple or lesion areas, uh, bacteria, most commonly Staph aureus, can invade through the lesion, therefore leading to this condition. and it can even lead to septicemia, and the symptoms include pain, swelling, and erythema. The management are empirical antibiotics such as flucloxacillin, as well as continued feeding or milk expression. If the patient is presented to you with septic symptoms, then IV antibiotics is recommended. If abscess develops, then repeated ultrasound guided aspiration should be done until resolution, and surgery is only indicated if the skin is threatened or necrotic, which is usually uh, not the case.
Okay,
For
what do you mean by the skin is threatened?
um, it means what I meant by the skin is threatened is when there's mainly is when there's necrosis.
Okay, when you see a breast abscess, you can see that the usually the skin is erythematous. So
Yes.
is it means it is threatened?
No, because that is the usual presentation.
Okay, okay. So surgery is indicated is if it's already satu necrotic or it's already ruptured lah.
Yes, ruptured. Yeah.
Okay,
Correct.
ruptured. When it's ruptured already, so you need to open up the the abscess properly for proper evacuation and dressing.
Yes.
Okay, so if you see the breast is only like erythematous skin, or sometimes the skin can be normal in a deep seated abscess. Okay, in that kind of operation, you can just aspirate the abscess. It can
Yep.
be done once, or it can be repeated, or sometimes it's difficult by blind technique. You need ultrasound guided. Okay, that one is depends on the case to case basis. Okay,
All right.
next.
Okay. For non-lactational mastitis, it is usually periductal with active inflammation in non-dilated ducts, and
Okay,
this.
in non-lactational mastitis, the management is the same except in a lactating breast,
Mhm.
the breast need to be expressed.
Yes. Yeah. Yeah.
Okay, proceed.
Yeah. Management is what I would like to highlight is non-lactational mastitis is active inflammation in non-dilated ducts, and usually it can be confused with duct ataxia. However, this is the main thing that differs from duct ataxia, which will be explained later. Um, Moving on to the next slide. Excuse me, miss. It seems like the call will end in 10 minutes. Do we have an extra link after this, Ibrahim? All right. Okay. Moving on to the tuberculosis of breast, which is rare, and it is associated with pulmonary TB or tuberculous cervical adenesis, and usually occurs in
Okay, let's go to
the new
the
link.
new link straight away.
All right, doctor.
Okay.
multiple chronic abscess and sinus, which are typically looking bluish, attenuated appearance of the surrounding skin. You can see from the pictures I've provided. And the management is, of course, anti-tuberculous chemotherapy as well as mastectomy. However, mastectomy is only restricted to patients with persistent residual infection.
Okay, mastectomy is for those yang not resolved with the most of the cases will respond with the anti-TB unless you got a wrong diagnosis lah. Okay, mostly we resolve with the anti-TB except sometimes it involve like the whole breast. Okay, involve the whole breast and it's not like resolved with the anti-tuberculosis or it distorted the breast. Okay,
Okay.
sometimes you can do something to to reshape the breast, okay, do some breast reconstruction, but that one is usually not needed. Okay, the main treatment is anti-TB. So if you find our patient not resolved with the anti-TB, you need to ask why, because most of the patient resolve. So it could be wrong diagnosis or it could be non-compliance.
Okay.
Proceed.
Doctor, just one question. So, if the patient presents with sinus or fistula, should we also do mastectomy in that
No,
sense,
it will resolve with the anti-TB.
or it will resolve
In
the
most of the
sinus itself
cases
will
will
also?
resolve with the anti-TB.
All right, doctor. Okay. Okay. Next slide, please. Okay, next is chronic granulomatous mastitis. It is diagnosed from the name itself. It is diagnosed histologically. It is due to when this inflammatory breast disease, which leads to epithelial damage, for example, recurrent abscess or chronic abscess. So the presentation, from the pictures that I've provided, you there, focus on E and F. In the breast, for E, the breast histology stain with H and E is presented with multi nucleated giant cells and inflammatory infiltrate composed of foamy macrophages, lymphocytes, and few plasmocytes. And when enlarged to 40 times view, you can see it clearly in F, picture F. So the management is antibiotic therapy, abscess drainage, as well as corticosteroid, high dose prednisolone for 3 to 6 months. If the patient presents with mild symptoms or refuse oral corticosteroid, we could give them topical application of hydrocortisone acetate 0.5% once daily, or methotrexate if patient complains of relapse or cannot tolerate high dose of corticosteroid therapy. However, methotrexate must be in low dose regime, 7.5 to 25 milligram weekly dosage, plus folic acid uh, should also be applied once daily, or and this therapy should be done once per week, as well as surgical excision if there is insufficient response. And usually we would do wide excision, um, as well as
Okay,
mastectomy.
for
The
chronic
last,
granulomatous mastitis,
okay.
antibiotic therapy only if there is presence of abscess. Okay,
Yeah.
because chronic granulomatous mastitis is a chronic inflammation. Okay, chronic inflammation. So the treatment is steroid. Okay, it's not a high dose steroid. Okay, it's just okay, it's not high dose. Okay, it's not high dose. Okay, and then when you give steroid, you need to taper it down. Okay, so usually for the when you give steroid, you must remember the effect of steroid. Okay, steroid toxicity. When moon phase, okay, patient can have like underlying diabetic can worsen.
Yep.
Okay, sekejap.
Yeah. Oh, okay, okay, sure.
Okay, so when you give steroid, you need to uh, uh, monitor the lesion with the response, meaning every 2 weeks usually you give 2 weeks steroid and then you see the response. And then if responded, then you can taper it down, okay, every 2 weeks. Okay, but if it's not respond, maybe you need to have like a bit longer steroid, but you must remember of the side effect. Okay, patient diabetic can have like a haywire sugar. Okay, that's why steroid need to be cautious. Okay, usually surgery is rarely needed, but in some cases, okay, if uh, 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 not responded, maybe, okay, or sometimes in those that still had lump, okay, still had lump. Okay, mastectomy, if only it involve like the whole breast not responded well with the steroid. Okay, you can do mastectomy, but you must remember CGM is a benign condition, so mastectomy is rarely needed.
Yes.
Proceed.
Next is duct papilloma. It is a localized area of epithelial proliferation and usually presented with villous lesion, fibrovascular core covered by double layer of epithelium, and solitary for solitary lesion is usually mainly in lactiferous duct close to the nipple. And to remember, it is not pre-malignant, and it presents with spontaneous blood stain or clear watery nipple discharge in single duct alongside with palpable retroareolar mass. So the management is, of course, imaging of the lesion itself, ultrasound, diagnosis to confirm that it is not cancerous, core biopsy, and excision of the affected duct,
Okay,
micro.
ductal papilloma usually small, okay, small because it arises from the ducts. Okay, the ducts is very small, so it's very difficult to do core biopsy.
Okay.
Okay, core biopsy. But in cases of a bigger lesion, you can do core biopsy. Usually FNAC sahajalah. Okay, that one also sometimes is difficult because most of the cases is very small. Okay, 5 mm, 6 mm, 6 mm. Okay, so any lesion, any breast complaint, nipple discharge only ke lump ke pain, triple assessment. And then you go along the birak scoring and then you tengok apa yang you nak buat after that. Okay, in this kind of patient, ductal papilloma usually come with nipple discharge. Okay, usually, oh sorry, usually after triple assessment, okay, you can do microdocectomy. Okay,
Yep.
microdectomy. Group of duct resection is not called wedge resection. Okay, called total duct resection. Okay, microdectomy also.
Oh,
Okay, just whether you remove one lump or you remove the total duct. Okay,
oh,
see.
sorry. If the causative lesion is not found, then subareolar excision is of all ducts is indicated. Next is duct ataxia, which is dilatation and shortening of major lactiferous duct, as you can see in the picture, and it is a common involutional change appearing around menopause. Um, Menopausal time. It presents with spontaneous cream yellow or green discharge of the nipples, and from histologically, presence of plasma cell is characteristic of the ataxia. It can also calcify and can be presented in mammogram. Management is conservatively unless radiological findings suspicious of malignancy. And if there's persistent discharge, then subtotal or total nipple duct excision can be considered. Okay, next. Next is fibroadenoma, which is localized form of abnormalities of normal development and involution. So it is part of the abnormalities of normal development and involution, in which we classify as we broadly can call it as ANDI, and most it is most commonly presented in 15 to 30 years old. It presents with single rounded mass, smooth, firm, and highly mobile. That it usually quoted as breast mice because it is very mobile. For management is, of course, to exclude from cancer as well as from phyllodes tumor clinically, radiologically, and we can also do core biopsy. If it is enlarged, excisional biopsy is recommended. It may regress spontaneously, 85 to 95% of it. Um, then if they regress spontaneously, they may not require excision. And confirmatory.
Okay, for fibroadenoma, okay, when you do triple assessment, confirm it is fibroadenoma, it's either you conservative or you remove.
Yes.
Okay, either conservative or you remove. Because your slide is, this is already confirmed fibroadenoma. Okay, it's not like you are investigating untuk phylloides ke apa, no. Okay, so when you already confirm fibroadenoma, okay, less than 3 centimeter, usually you can just conservative, meaning just monitor saja. Okay, but if more than that, usually it won't regress, so you remove.
Yes.
That is another option. One more thing is you need to see the risk factor also of the patient. For example, this patient you confirm fibroadenoma but mother had breast cancer. So in this kind of patient, usually you counsel for removal of the fibroadenoma. Okay, proceed.
Okay. Next. Right. Okay. Next, and the final part of this presentation is phyllodes tumor. Occurs usually in middle age. It is described as slow growing, massive, and unevenly bosselated surface, and mobile on chest wall, with overlying skin necrosis. The management is depending on what type of phyllodes tumor it is. So for benign type, it is excision biopsy or white local excision. For massive tumor or recurrent tumor or even features of malignant type, is simple mastectomy with no lymph node uh, invasion.
Okay, you don't do lymph node dissection because phylloides. What is phylloides tumor? It is a sarcoma of the breast. Okay,
Yeah.
what do you mean by sarcoma? Sarcoma is really local invasion. So dia akan pergi ke chest wall, dia akan pergi ke pec muscle. So it local invasion. Okay, in a malignant type. Okay, rarely it goes to the lymph node. That's why you don't need lymph node dissection when you do mastectomy. So simple mastectomy is enough.
Yes.
Okay, so phylloides tumor is you don't do excision biopsy for phylloides tumor because of risk of recurrence is higher. So you do what? Local excision.
Oh,
Okay, if you already diagnose the patient prior to surgery, this is phylloides tumor. Okay, you do white local excision, not excisional biopsy.
oh,
Okay.
just white local excision lah. Tak ya excision biopsy. Okay.
No, but in some cases, okay, you diagnose it prior, no, you, let's say the true cut biopsy say this is a fibroepithelial lesion. Okay, it could be phylloides, it could be fibroadenoma. Okay, you do white local excision also. Okay, sometimes it is atypical pula. The diagnosis pre-operatively could be this could be just fibroadenoma, and then you do excision biopsy, but then the HPE came back as phylloides tumor. So that one you just do excision biopsy because you don't know the pathology before the surgery. Okay, that can be.
Okay.
But when you diagnose patient as phylloides tumor, you do white local excision. Okay, proceed.
Okay. That is the final slide for this part.
Okay, Assalamualaikum. I'm Shazwani. I will continue on the 10M staging for breast cancer. So this staging, uh, back the first slide. So the TNM staging was according to the American Joint Committee on Cancer Detection. So the TNM stand for the primary tumor, the lymph node involvement, and also the metastasis site. And also this each of the characteristic of this tumor can be evaluated and reported either clinically using the physical exam with or without the imaging. So the function of this staging is for the treatment planning, indication of prognosis, and also to assist us in evaluation of the treatment results. So for the treatment, for the primary tumor, we assess for the size for the tumor. Where the basically the T1 is less than 2 cm, T2 2 to 5 cm, T3 more than 5 cm, and T4 when there is a direct extension of the tumor to the chest wall and or to the skin, or when it extended both to the chest wall and skin. So next is regional lymph nodes involvement. So we for the C and X, which is the regional lymph node cannot be assessed. So it example in a previously removed lymph node. And zero is no nodes involvement, and one it's mobile nodes, and two is fixed omitted nodes. And three is when there is ipsilateral internal memory nodes involved. If you can see in the table, there is a classification. There is a lymph node involvement in the level 1, 2, or 3 axillary lymph node. So I will
Okay,
explain
you don't
where
have
is
to memorize all those things. You know, the important things that N3 is supraclavicular lymph node involvement. Okay, because you cannot palpate. Usually internal memory nodes is rarely enlarged. Okay, but you can palpate supraclavicular lymph node. Okay, so N1 and mobile, N2 fixed or method, and 3 when already involved the supraclavicular nodes. Okay, proceed.
okay. Next slide. So this is the level of lymph node involvement in the axillary. So the level 1 is lateral to the lateral border of the pectoralis minor muscle. Level 2 is it lies under the pectoralis minor muscle between the muscle lateral and middle border. So the level 3, it is medial to the middle margin of the pectoralis minor muscle. It's the supraclavicular interclavicular. Okay, next slide. So the next slide is distant metastasis of the tumor. So we assess for the presence or not of the distant metastasis such as at the lung, bone, or liver. So M0 is there is no clinical or
M1 can
radiographic.
be anywhere. Okay, tak kira lah lungs, liver, bone, brain. Okay, as long as it is distant metastasis, it is M1. Okay, proceed.
Okay, so next slide. So this is the uh, grouping for the staging according to the size of the tumor, the nodal involvement, also the metastasized. Next slide. So for the grouping for the early breast cancer is the ductal carcinoma in situ, the stage 1 and stage 2. So for investigation, if the patient came with symptoms of if the patient is
Okay, for
asymptomatic.
you all, untuk staging, okay, CT thorax abdomen pelvis, okay, one of it. MRI rarely done. Okay, depends on where is the metastasis. For example, in the bone. Okay, sometimes the ortho would like to know the the spinal cord involvement. Okay, so they do MRI. So basically jarang to buat MRI. PET scan if CT scan is inconclusive. For example, CT scan kata there is there is a liver lesion, okay, unable to rule out metastasis. Then you can do PET scan. Okay. Bone scan sama juga. If CT scan is like example unable to rule out bone mass, you can do bone scan. Okay, or patient already don't have any symptoms, CT scan doesn't show any bone metastasis, but it is already stage 3, then you do bone scan. Okay, that's
Thank
all
you.
to know. Okay,
Okay.
proceed.
Yeah, that's all for the my part.
Yes, Assalamualaikum. I'll be presenting about management of malignant breast disease. Next. So for the introduction, basically we have around 6 management of the malignant breast disease, which consists of surgery, BCS, breast reconstructive surgery, chemotherapy, radiotherapy, and hormone and targeted therapy. The aim, our aim is to reduce the chance of local recurrence and risk of metastatic spread. And we can divide it into three category in the CPG, which is early breast carcinoma, locally advanced breast carcinoma, and metastatic breast carcinoma. For the early breast carcinoma, we can do BCS, breast reconstructive surgery, and adjuvant radiotherapy, which is a must when we do BCS. Also, a mastectomy. And for the axilla, sentinel lymph node biopsy can be done in axillary clearance. For the locally advanced breast carcinoma, we can divide it into operable and inoperable. For the operable, uh, mastectomy and axillary clearance can be done, and neoadjuvant chemotherapy with or without anti-HER2 therapy depending on the HER2 status of the breast cancer, whether it's positive or negative, and followed by surgery. For the
For this kind of patient, okay, management all these things, okay, you don't have to know too much on this, okay, because we won't ask you whether this one is for mastectomy ke neoadjuvant ke ni, okay. So but what you must know is, okay, for early breast cancer, the lump is small, you can do breast conserving surgery. Okay, plus adjuvant radiotherapy, okay, as you mentioned, is a must, or mastectomy. Sorry, when you're talking about BCS, it means white local excision. Okay, white local excision plus axillary surgery, which can be sentinel nodes or axillary clearance. Sama juga mastectomy plus sentinel nodes or axillary clearance. Okay, surgery tak banyak tau. It's either white local excision plus yang early breast cancer ni. Ini je yang you perlu tahu. BCS or mastectomy axillary clearance or sentinel nodes. Itu sahaja. Okay, whether to give chemotherapy or not prior to surgery, it depends on case to case basis also. Okay, because if you look at the locally advanced, some patient you do mastectomy straight away, some patient you give chemotherapy dulu. Okay, depends on cases. For example, patient datang dengan apa tu, poderone already the breast, kan dah ada poderone almost apa tu, occupying the part of the breast ke, okay, can be the whole breast ke, or some ulceration is already there. Okay, so in this kind of patient, it is deemed inoperable dulu. So in this kind of patient, you can give neoadjuvant dulu, and then see the response and do the surgery. And then later on, tengoklah whether you can resume with, let's say, hormonal therapy ke, okay, targeted therapy ke, depends on cases. Okay, metastatic, of course, palliative. Palliative care can be just medication, meaning painkillers, dressing. Okay, it can be, let's say it is hormone positive, you can give some hormone. Okay, in some patient, you can do palliative surgery. For example, in a bleeding tumor, ulcerated tumor, okay, uh, uh, so it is already symptomatic lah in this kind of patient, kan, berbaunya, bleedingnya, okay. That kind of patient, you can do mastectomy for that patient just to control the disease, okay, to improve the quality of life of patient lah, isn't it? Other than that, okay, in some patient juga kalau HER2 positive, you can give Herceptin. Okay, palliative care ni also involve, for example, patient come with pleural effusion, you do chest tube, you give oxygen. Okay, for like bone metastasis, painkillers, treatment for hypocalcemia. You can give um, pamidronate, okay, for hypocalcemia. Okay, all those are palliative care. Palliative care is a very broad topics. Okay, it's very broad topics, and you need to see where is this maths. Okay, where is the maths? For example, again, some more brain maths. Okay, some brain maths you can do some apa tu, radiotherapy, or you can do some ablation. Okay, depends on the cases lah. Okay, depends on also the ECOG status of the patient. For example, patient yang metastatic lesion, but apa tu, the ECOG status is 3-4, tak boleh buat apa tu, tak boleh bangun dah because of the bone metastasis. So in this kind of patient, you don't go too aggressive. Okay, more of like just to improve the quality of life, make the patient comfortable. But some patient with bone metastasis, with lung metastasis, okay, small, small amount of metastasis, they still can go around. ECOG status is very good. So in this kind of patient, you go a bit more aggressive. Okay, in terms of the treatment. Okay, proceed.
Okay, next slide. Okay, we go to the breast conservation surgery. Number one in the
Cakap tadi ni, okay, BCS, white local excision, you don't need to know the technical issue of it. Okay, don't need to know the technical issue of it. Okay, proceed.
okay, for the selection criteria for the BCS, usually there is a 1, 2, 3 rules that we can understand this. One is one lesion clinically and mammographically. Two is tumor. There is
Not necessarily one lesion only, it can be few lesion. Okay, that's why on the technicality of this BCS is not for your level. Okay, as long as you did not remove the lesion is amenable to be removed with the surrounding tissue less than 20% of the breast, okay, it is amenable for BCS. Dia ada 2-3 lesion pun but small, kecil-kecil je. 1 cm, 1 cm, okay, duduk dekat-dekat. When you do surgery, you can remove, you can remove less than 20% or 20% of the breast, then that patient is can go for BCS. Okay, okay. The size of the tumor depends on the size of the breast also. Okay, if the breast is cup A but the lesion is 4 centimeter or 3 centimeter, you need to remove like 5 centimeter of the area. So it could be this patient cannot go for BCS also. But if that tumor is like 4 centimeter but the breast is like cup C or D, you can do BCS. Okay, that's why this technicality is not for you all. Okay, proceed.
okay, next. Okay, this is some type of the mastectomy.
Yang ni dah tak ada dah all this thing. Masih lagi ada in your slide. I know you copy from the previous slide, previous apa tu? Previous seminar. Tapi you kena tengok lah. You all ni janganlah copy and paste saja. You don't do that. All this hashtag lah whatsoever. All those are history. Okay, proceed.
Okay, proceed. Next. Okay, this BCS that we offer after mastectomy. Usually, we want to try our best to restore natural breast shape and reestablish symmetry and create a nipple areola complex back after we do mastectomy. Either we do it by skin sparing mastectomy when we put implant or tissue expander or tissue transfer by a myocutinous flap that we take flap from the our part of body, like in the transverse rectus abdominis, in the latissimus dorsi, buttock, and inner thigh. And there is two type of the uh, breast reconstructive surgery, which is immediate or delayed. Immediate when we perform at the same time as mastectomy, it has some positive impact, which is a positive psychosocial impact. It have more cosmetic result to the patient. For the delayed reconstruction, it performed at a later time, months or year after the mastectomy, and it's done for patients who need adjuvant chemotherapy and have less optimal cosmetic result to the patient. Next, if the axillary surgery that can be divided into uh, axillary clearance and sentinel lymph node biopsy is a part of TNM staging, and it can be a prognostic factor in the breast cancer. For the sentinel lymph node biopsy, sentinel lymph node is the lymph node that first to receive lymphatic drainage from tumor, and we do in the early breast cancer less than 3 cm and clinically not negative disease. When it's in the uh, examination and imaging, we can't see any axillary lymph node involvement and negative on cytology and histopathology in case of the axillary lymph node. Okay, next. This is just the picture of how it's done. Next. Okay, for the axillary clearance or axillary lymph node dissection, we do when there is problem with the is positive sentinel lymph node biopsy more than two in early breast carcinoma and axillary disease in preoperatively, and the physical level is depend on the in relation to pectoralis minor muscle. Usually most node at level 1 below the lower edge of the pectoralis minor muscle. Level 2 is at the level of the muscle like in the picture, and level 3 is above it, and level 2 clearance is usually accepted by most surgeon in the case of the axillary clearance. Next.
Okay, not most surgeon I said. The standard now is level 2 only. Okay, level 2 only. You proceed.
This is the algorithm.
This one. You don't have to know all these things. Okay, the one that I mentioned to you just now is adequate for you. Okay, proceed. Next.
Next. This is non-surgical management. We have talked about chemotherapy that usually is the treatment of the chemotherapy will depends on the overall health of the patient, age, medical history, type and stage of the cancer, and tolerance for specific indication and procedure in the chemotherapy. And it's given in cycles. It given before surgery, or we set of neoadjuvant for to shrink the tumor, and it given after surgery to reduce rate of the cancer recurrence. Combination chemotherapy is a effective first line treatment in metastatic breast cancer. Next. Okay, for the neoadjuvant chemotherapy is offered to the patient with triple negative or HER2 positive early breast cancer to enable BCS to be done. And still, we need to discuss the benefit and risk with the patient. Adjuvant chemotherapy is recommended for intermediate and high risk patient based on this table. So, you know, the adjuvant is given for surgery to eradicate micrometastasis in the breast cancer, because breast cancer we consider as a systemic disease with already circulating malignant cell until proven otherwise. So this is the table that we categorize the patient in the low risk, intermediate risk, or high risk.
Okay,
Next.
okay. You don't have to know the how to reach this the patient. Okay, proceed.
Okay, you see.
Okay, this one also you don't have to know the chemo agent.
Okay, next. Okay, this is radiotherapy. Number one thing that we must remember that uh, is a very important component in the breast conservation therapy. It must be given after BCS, and usually it's just the therapy that involve high energy X-ray or gamma that target tumor at the site and is effective in killing cancer cells that may remain after the surgery has been done or recur when the tumor was removed. and usually is given over a period of 5 to 7 weeks. It's performed 5 days a week, and each treatment takes about only 15 minutes. Next, this is the follow up, the recommended uh, regular follow up. 3 to 4 months for the first 2 years, 6 to 8 months for the subsequent 3 to 5 years, and annually thereafter. And annual ipsilateral after BCS, and or contralateral mammography after mastectomy with ultrasound and breast MRI when it's needed. And we need to encourage the patient to adopt a healthy lifestyle, including diet modification, exercise to improve the outcome of the treatment. Okay, pass the presentation to Ibrahim.
Okay, that one is already mentioned by your friend, isn't it? No adjuvant before surgery, adjuvant is after surgery. That's all. Palliative is just using the same chemotherapy. It's just that the aim is for palliative. Okay, for new adjuvant and adjuvant is of curative intent. Okay, proceed. Next slide. Next slide. This one pun sama juga. Kawan you dah beritahu dah tadi. So this one you don't have to know. Okay, proceed. Next. Okay. For chemotherapy, okay, you don't have to know when to give chemotherapy. It's not your level, okay? But you as long as you know there are few treatment to be given to a cancer patient, breast cancer patient. Yang you cakap tadi itulah six management. Okay, chemotherapy ke endocrine therapy ke will be decided by the oncology. Okay, endocrine therapy only for hormone positive breast cancer, ERPR. Either you give tamoxifen, AI ke, how many years? Okay, it's not your level. Okay, as long as you know there is endocrine therapy, example is tamoxifen, okay, aromatase inhibitor, okay, that's already enough for you all. Okay, proceed next. Okay, sama juga all these things. Ovarian abrasion, suppression, okay, all these are part of the hormone. Okay, hormone therapy can be divided into medical or surgical. Or surgical lah, satu lagi surgical. Okay, ovarian oophorectomy. Okay, oophorectomy. Or this one is fall under apa? It's not medical. I can't remember lah. Apa lagi satu kategori dia. Okay, fine. But one of it is either by ablation. Okay, ovarian suppression, you can give like GnRH analog. Okay, all these things are just to reduce the estrogen level. Okay, HER2 only for those with HER2 positive. It's not 6 months, it's usually 1 year. Can be also for 6 months. Everything is depends on the tumor type whatsoever. That's why it's not at your level. Okay, you just know HER2 positive, you can give anti-HER2. For example, trastuzumab. Okay, next. Okay, yang ni pun sama. Radioterapi, kawan you ada beritahu tadi. Next. Yang ni pun kawan you ada beritahu juga tadi. You ni tak tengok slide sama-sama ke? Proceed next. Okay. Okay, any question? Any question on the breast cancer? Or ada for or benign or malignant breast cancer? Hmm. Anyone can answer that question? Anyone can answer? Why more frequent in the first 2 years? Because that is the most recurrence can occur. Okay, recurrence if the patient apa deem lah to recur usually within the first 2 years. That's why the first 2 years you need to a bit close monitoring of the patient. Okay. After 2 years, the risk of recurrence is lower. Okay. After 5 years, it's much lower. Okay. That's why the follow up is more long. Okay. Compared to the within the first 2 years. Okay, but you must remember when you do follow up, you need to ask the patient about the new symptoms, any sign, any symptoms of metastasis. Okay, check for any new lump. Okay, check for metastatic sign. Okay, and then surveillance in terms of mammogram. Okay. So based on that mammogram, you tengok balik. Okay. Based on that birak scoring lah. Okay. You tengok balik birak score. Kalau birak score 1, 2, then you are happy. But if the patient develop new lump, okay, you look back at the birak scoring. So you need to do triple assessment again. Okay. Because of recurrence or metastasis lah. Okay. After like 1 year after surgery, okay, patient complain ada back pain, okay, then you have to investigate whether this is bone metastasis or not. Okay, so nak investigate macam mana? It can be by CT scan, okay, or bone scan. Okay, everything is based on cases. Okay. Lagi question?
Doctor, I have a question.
Hmm.
I've met a patient with breast cancer, and she presents with this um very, memang nampak dia punya breast cancer lah, the necrotic, the skin dimpling, as well as bleeding around the areola. I believe this is also your patient as well. But just out of curiosity, why don't we do mastectomy for this patient first? And why does this patient manage by chemotherapy first instead of just mastectomy? Because this patient already has axillary lymph node metastasis as well.
Patient got bleeding?
Yeah.
Patient bleeding?
Patient got bleeding. Yes.
Hmm.
If I'm not mistaken, the patient's name is Kasuri. This is one of your patient, doctor. So
Do you think you can operate on that patient with that breast? How
uh,
the mastectomy being done? You remove the whole breast, right? And then you nak tampal dengan apa? Of course, you have to tampal the chest wall with the skin. That
uh,
patient, the skin already involved. So you
oh,
nak tampal dengan apa? The chest wall dia. Isn't it? You akan, when you do mastectomy, you will remove the whole breast, leaving the pectoralis muscles. Okay, so everything gonna be shown up. So you nak tampal dengan apa? You tak ada skin nak tampal. Okay, dengan ada lymph node ni everything is already involved the pectoralis muscles also. So you nak buat apa? You can't do surgery at that patient because it is inoperable.
oh, okay.
Inoperable. So inoperable, you jangan buat apa-apa dulu. I mean, bukan jangan buat apa-apa. You don't do surgery first. Okay, you give chemotherapy dulu to control the disease, the lesion, shrink the tumor because they're bleeding, ulcerated. So let it dry, stop the bleeding. Okay, don't straight away go for surgery. And some more in this kind of patient, if you do surgery, apa tu, the risk of like wound adhesion, okay, is higher lah because the skin that you will use to close is could be tumor skin. Okay, it won't close, it won't heal. Okay, so give chemo first to that patient and then you see back lah, that patient also staging pun tak ada lagi. Kalau stage 4 nak buat apa, you tak payah buat apa lagi lah, you bagi chemo dulu, see the response. Kalau the lesion is already shrink, no more bleeding, then proceed dengan other things lah like hormone. Okay, you don't do surgery in that kind of patient because surgery does not improve the survival. When you're talking about breast cancer, any cancer, you're talking about recurrence, you're talking about survival of the patient. Okay, you when you do something, you want the patient to live longer. Okay, memanglah kita tahu yang umur tu bukannya kita punya kan. Okay, but based on study, okay, this kind of patient, okay, if you give chemotherapy, the uh, the 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 survival will be like say 2 years, but without chemotherapy the survival less than 2 years. If you give hormone, it will add on another 1 year, let's say. Okay, so you want to know the survival of the patient. So when you do surgery, will it change your overall survival? If not, then why should you do? You put patient under general anesthesia, under surgery, which is not necessary. Okay, any other question?
All right, doctor. Thank you for the answer.
Okay, any other question? Okay, tak ada, that's all. Thank you very much. Okay,
Thank you.
apa tu? I'm going for my haji this next week. Sorry, not next week lah. I will be around until Thursday. So siapa-siapa yang nak ambil sign, all this seminar whatsoever, please meet me before that. Okay, I won't be around from Friday onwards. Okay. Okay, Assalamualaikum.